Oh, recording has started. Okay, so please keep your microphone on mute during the presentation. If you forget, I'll mute you. I watch that pretty closely. There is time after the presentation for question and answer, or you can enter your question into the chat box and I'll watch that for Dr. Worth, or you can raise your hand, whichever you prefer. So tonight's presentation is evidence-based management of hip and knee arthritis. How do we incorporate AAOS clinical practical guidelines? Presented by Dr. Lucian Worth. Dr. Worth practices at Forte Sports Medicine and Orthopedics and is a board certified and fellowship trained orthopedic surgeon specializing in primary and revision hip and knee replacement. Dr. Worth developed a passion for orthopedics as a child while playing with the hip and spine models his mother.
Amy, you don't have to read the rest of that. It's if they want to talk to me about my passion moving forward, like they can give me a call.
Okay.
So let's just move on.
All right, great. Well, thank you so much for presenting tonight, and it's all yours.
All right. Well, thank you very much. Appreciate anybody who's on taking the time. So when I was considering giving this talk, several months ago when we decided to do this, the goal was to basically envision a talk which would kind of cross paths between what I do as an orthopedic surgeon and what the majority of the audience will do, as physicians taking care of people with hip and knee pain. So that's where the evidence piece came in. As a surgeon who used to be in an academic practice, recently moved into private practice, evidence-based medicine, the academy, means a lot to me, in developing a fellowship and training human beings. So that's kind of where the talk started, but it migrated a little bit, mostly because I got bored and because I want you guys to know what we're passionate about here as well. So that's the start of it. So in terms of disclosures, Amy already kind of mentioned this briefly. None of this is terribly relevant in my opinion, mostly because it's consulting pieces, and we're not really going to be talking about implants until potentially the very end. So in terms of an overview, when I was trying to envision this talk, most of what I do, or a lot of what I do, is complex revision, infection, hip and knee replacement work. But the easy stuff, the primary hip, the primary knee, the care of the patient with hip or knee hip or knee arthritis or moderate arthritis that's still trying to understand what their options are, is still a big part of my practice. And that's kind of where the crossover is. So the goals for me was to honestly just reevaluate what our academy is. The AAOS is our academy, in what the clinical practice guidelines support or provide, just to kind of get back to the granular nature in terms of the recommendations that I have to my patients and how supported is that with orthopedic research. I wanted to review some select guidelines that I think kind of cross the paths between the audience today and my own practice, and then leave plenty of time for question A. But again, I would just challenge you guys to scribble down some questions or raise your hand and talk to Amy, because I think interactive input is always a beneficial thing in terms of this kind of discussion, because again, this isn't more me talking to you, it's more of a discussion about how we're treating our patients and how we're doing it in an evidence-based way. And I think for me, the big question when I started this was, what is the cross section of our practices and how can we make that optimal in terms of how we can define that and how we can work together. So overview. So the Academy, AOS clinical practice guidelines, I wanted to think about diagnostic imaging. I mean, that's the first start. Somebody comes into your office, maybe they're 40, maybe they're 30, maybe they're 70. What are the diagnostic imaging modalities that we should be using and utilizing, both to maximize, the patient's time, minimize their cost, and also minimize cost to the overall medical care of the human. Conservative management, what it really does work, physical therapy, medications, injections. I have a lot of crosstalk with some of my patients and some of the primary care providers that I work with or that I share patients with, and we're not necessarily always on the same page. And I wanted to know or re-review what my academy tells me, what I do, and also would be interested to hear what you folks think in terms of how we should be managing these patients and in what capacity. Dental prophylaxis is always a big question. I was a little bit frustrated with my own academy based on what I've been told, what I've been taught, and we'll get into that. Other things, tobacco, obesity, these are things where, I really feel like we should, maybe have a little bit of a closer relationship between the doctor that, takes care of the patient on a day-to-day basis and the surgeon, how we can collaborate to mitigate risk for our patients. And then I did want to do just a quick brief aside in terms of patient follow-up and an exact tech recall, which I think affects a lot of the patients here in Carmel, in Noblesville, et cetera. And we can talk about that briefly, but mostly just so you guys are aware of this concern that it's affecting a lot of patients and can certainly affect the revision orthopedic surgeon. So, I mean, just kind of as background, what is the AAOS? What is the Academy? So the American Academy of Orthopedic Surgeons is the world's largest association of musculoskeletal subspecialists. It was founded at Northwestern University in 1933. Currently greater than 40,000 members. So like that's our academy. That's our baby. That's kind of what we try to define the choices we make on based on pure science. Clinical practice guidelines, they were devised by the Academy, by our leadership, provide evidence-based programs in medicine for current orthopedic diagnostic, treatment, and post-operative procedures. Today, we're kind of mostly going to talk about, diagnosis. We're going to talk a little bit about the non-operative aspect, mostly because that's kind of where our potential our practices intersect. So these CPGs or clinical practice guidelines, they were developed to serve as a reference point. And again, part of the issue that I kind of understand with these is that, we set a really high bar in terms of the evidence-based medicine, which offensively to me as an orthopedic surgeon is a little bit lacking in orthopedic surgery. And we'll talk a little bit about that, but also why we still feel comfortable making the recommendations we do. So the Academy guidelines, were basically formulated, and there's hundreds of these, and we're kind of going to distill them down to just a few today based on time. But a work group of experts, which included orthopedic surgeons, primary care physicians, rheumatologists, did a full literature review. Again, they have a seizure-inducing algorithm where basically they looked at the strength of quality of literature. And in orthopedic surgery, there just isn't a ton of prospective randomized trials, which is the strongest or the highest. But they distilled this down with the best that they could in a multidisciplinary way, and gave strength and quality descriptions. So again, it's hard to argue with 4 stars versus 1 star, but we can kind of discuss that. But basically, we're just going to go through a few of these today, and then talk about how to manage risk, how to mitigate risk, how I feel about how to transition from conservative patient care to surgery, and who's appropriate. So the first thing I thought about was imaging. So when I'm in clinic, I see a lot of patients, a lot of referrals, and they've had some imaging done. Sometimes they've had no imaging done. It kind of depends on their insurance, the referral patterns, et cetera. But I was a little offended that my own academy gave no imaging guidelines for a patient coming in with hip or knee arthritis. In specific, when you talk about infection or more complex things, we got into that. But in terms of diagnostic imaging for a patient who's 55 years old with hip or knee pain, we have no guidelines. So what I do in practice for the hip, it's a weight-bearing tube view, and an AP pelvis to me is important. Weight-bearing is important because a lot of times that that joint space will close down with weight-bearing, will be falsely elevated if you're supine or just laying down. And a frog leg or a cross table ladder will give you an idea of the anatomy of the femur. For the knee, weight bearing also extremely important. Most important to me also is a flex PA. So that means that the knee is flexed about 30 degrees. And you're taking an x-ray, which is evaluating cartilage in a different aspect of the knee, as well as a lateral and emergent. So if you look at this knee, so this is just an AP of a knee, and this is non-weight bearing. Here's an AP of a knee, which is weight bearing, but also flexed slightly. And you can see there's a fairly significant difference on the inner half of the knee, or the medial knee, in terms of the joint space loss. And this is a patient with an achy knee, doesn't have mechanical symptoms. This has been chronic for several months. This is not a human being who needs an MRI as a first stage in terms of imaging. But if you get the picture on the left, maybe you say that doesn't look so bad. If you get the picture on the right, maybe you say, okay, now we know we have some significant arthritis. But again, we don't necessarily need an MRI in all of these patients. So for me, when I'm looking at diagnostic imaging, which unfortunately my academy has not helped me with in terms of talking to some primary care physicians or even talking to my residents, my fellows, weight-bearing films I think are critical because otherwise that joint space may be fully open. A flex PA on a knee is important. That's about a 30 or 35 degree view, which shows a different part of the knee, which is often damaged. A lot of patients will have pain with weight bearing, going up and down stairs, things like this. An MRI, I get a lot of patients with an MRI and they don't even have x-rays yet, but they've got bone-on-bone arthritis. Really, MRIs are more reserved if your patients are above 50 for significant catching, clicking, popping or locking, mechanical symptoms, sharp shooting symptoms, maybe something acute. But x-ray, fairly cheap and oftentimes can obviate the need for an MRI. So again, this is just kind of demonstrating that the inner half of the knee, which is the most common area to develop arthritis, weight-bearing views or a flex PA view can show something much more dramatic that we don't necessarily need an MRI for. In terms of physical therapy, so the first thing that I often think about when I meet a patient with hip or knee pain, is it the joint? Is it intra-articular? Is it more extra-articular? Is it muscles, tendons, etc.? So I looked at what the Academy recommends in terms of physical therapy. So for the hip, again, a moderate recommendation. So PT could be considered for moderate symptomatic arthritis. Again, I would just get an x-ray for these folks, not necessarily an MRI. They looked at high quality studies. And again, a high quality study, because we set the bar so high, is a prospective randomized study or a study which is very tightly controlled. The algorithm, again, is potentially seizure inducing and beyond the scope of this talk, but a moderate recommendation for hip arthritis. The reason why that is that the muscles around the hip are strong and the hip is a simple joint. When we go to the knee is a much more complex joint in terms of translation, rotation, and flexion, and the muscles around the knee are not as strong. So patients actually improve quite a bit more with preoperative physical therapy with more moderate arthritis. And so the Academy has a strong recommendation in favor of physical therapy for the knee. The hip is more plus or minus based on my understanding. In terms of oral medications, so I meet a lot of patients, and most patients tell me they don't like pills and they don't like medications, especially the younger ones. Elderly patients say, I'm already taking 40 pills. I don't want to take any pain pills or any medications. Big difference between narcotic pain pills and anti-inflammatory pain pills. So in terms of oral NSAIDs, what my academy would recommend, there are 34 high quality studies, 23 moderate quality studies, significant reduction in pain and improved function, improved range of motion with a consistent oral anti-inflammatory. Now that obviously brings us to kind of this disconnect between the primary care physician who's trying to take care of the patient as a whole and the orthopedic surgeon who's trying to treat a specific entity in terms of hip or knee pain. But again, I don't think those necessarily can interact well. I get a lot of patients who tell me, well, my primary care doctor said I can't take anti-inflammatories because they're worried about my kidneys. So what I tell patients is, well, I'm worried about your knee pain. If your kidneys are bad, I agree wholeheartedly. We shouldn't take anti-inflammatories that are metabolized by the kidneys. If your stomach is bad, maybe we move to a COX-2 like a Celebrex. But on the whole, if your knee pain is bad and you don't have terrible kidney issues, as long as we're keeping a close eye on that, a consistent oral anti-inflammatory can be dramatically beneficial to your lifestyle, maybe obviate surgery for quite some time. And the research from the orthopedic perspective supports that. During the Q&A session, I guess I would challenge anybody to talk to me a little bit more about that because I'm a big proponent of anti-inflammatories in somebody with healthy kidneys. Certainly, we have to worry about the GI system if we're not using Celebrex or if there's an insurance issue. And certainly anybody on anticoagulation or with cardiac issues is another concern. So as our patients get more elderly with bigger issues, something to consider. But again, I find it interesting that patients often tell me a consistent oral anti-inflammatory is something they've been cautioned against, but not necessarily explain why or specifically what the issue would be. I usually tell my patients I'll give you a month with a refill moving forward. If it's something that is really affecting your quality of life in a positive way, we need to have a definitive conversation with your primary care physician. In terms of injections, I get a lot of questions about different types of injections, things outside the box. Occasionally I'll get a patient who spent several $1,000s on some sort of stem cell procedure, things of this nature. The Academy kind of really hones it down into things where there's high quality studies, which are prospective, randomized, things of this nature. In terms of corticosteroid injections, which is the most common that I perform, and I think, certainly that is a cross section in terms of practices between a primary care doctor and an orthopedic surgeon who treats hip and knee pain. In the review, which was recently done in 2022, 18 high quality studies, pain and function improved for up to 3 months and potentially longer with intra-articular corticosteroids. I tell all my patients, it does have an immune modulating effect. That's how it modulates the inflammation caused by your arthritis. That's how it helps with your pain. So we don't recommend steroids any more often than every 3 to 4 months. Do not recommend surgery within 3 months in terms of a hip or a knee replacement. In terms of hyaluronic acid or viscosupplementation, interestingly, they've kind of modified that recommendation between their initial CPG, 10 or 12 years ago and the most current one in 2022. So looking at 28 studies, 17 which they felt to be high quality, really no clinical benefit. And honestly, here we're not really doing that a ton. Mostly it's a combination of cost, reimbursement, and the fact that I just have not seen a ton of benefit, especially when people have significant radiographic hip or knee arthritis. In terms of PRP or other biologics, the jury, to my estimation, is still a little bit out. I think there's a lot of hope, a lot of potential there. There just aren't that many great studies that kind of support or refute whether or not these are an option, but I do think they kind of have the upper hand in terms of hyaluronic acid. The limited recommendation from our academy is mostly because there aren't any cross-sectional studies and there are a lot of heterogeneity there. One of the questions I get asked a lot by patients, a lot by primary care physicians, is dental prophylaxis. So I do hip and knee replacements for a living, and I treat a lot of complex patients. I treat a lot of patients who are not terribly healthy, to be quite honest. And those patients, dental prophylaxis, to me, at least in my practice, I've always recommended it. I was to some extent, I was a little offended by what the Academy came up with. And so the prevention of orthopedic implant infection in patients undergoing dental procedures, they said the practitioner might consider discontinuing routinely prescribing antibiotics. I agree that the super high quality prospective randomized research does not necessarily support that. Now, part of the issue with that is we're all trying to prevent infection. Infection is extremely rare, and sometimes a logical sense needs to take over a little bit. So again, high level evidence post dental procedure does support that bacteremia does occur. So that when you get your teeth cleaned or you have a tooth pulled, you do have bacteremia in your body, whether that sets up in the hip or knee. Again, there's moderate strength evidence suggesting that dental procedures of a standard nature are unrelated to implant infection. But a lot of what I do is based on science and medicine. This is the one recommendation I make to my patients that I would actually defer, away from the academy and say, an infection is absolutely catastrophic. The science, I think, is muddled. I recommend to my patients for a minimum of 1 year after surgery, and I recommend personally 2 when the soft tissue envelope or the blood flow to that area is still kind of being modified as the envelope heals. I would personally still recommend dental prophylaxis for a minimum of 2 years. I think a couple of my colleagues may be on this call or on this meeting. I'd be interested to see what their thoughts are, but most of my recommendations are based on science. I still recommend against the academy here, and that's based on fear because I treat a lot of infections. In terms of their recommendations, in terms of tobacco cessation, so we look at what our actual good studies are. Again, these are high quality, randomized prospective studies or high volume studies, which are more prospective. We've got 11 low quality studies, limited recommendation that patients may be at increased risk for adverse events. Part of the issue with that recommendation from our academy is that it's just not very granular, to be quite honest. So it doesn't really get into the meat of drainage, infection. So here at Forte, with our group, we strongly recommend smoking cessation minimum of 30 days after joint replacement. or I'm sorry, before and after joint replacement. And some of my colleagues just refuse to operate on folks who smoke, and I'll kind of get into that a little bit. And part of that is a study that I was involved with. It's been published in JBJS in terms of high risk, obesity, smoking, and it's really just a non-starter, because that is the one thing that most patients, obesity may or may not be something you can mitigate, especially in Indiana. But smoking is usually a personal choice, and if they understand the reasons why that smoking, which modifies the ability of the immune fighting cells of your macrophages to fight infection, usually explain it to them, they will stop. And from a primary care orthopedic intersection perspective, I think that's kind of a non-starter. In terms of obesity, I'm passionate about this. So for the first 8 or 9 years of my practice, I operated at IU. So I had a lot of obese, unhealthy, sick patients. And some of those patients were the patients that were the happiest after surgery. Many of those patients were one that other physicians wouldn't operate on, or they told they weren't candidates for surgery, but they were so debilitated, we rolled the dice. And when I say roll the dice, we take maybe a 3% risk instead of a 2% risk. And so, if you look at the Academy recommendations, if you look at the literature in its purest sense, again, there's just not a lot of orthopedic literature which is of that high volume, high quality, prospective randomized. You can't tell somebody to go lose 40 pounds or not lose 40 pounds and do a prospective randomized controlled trial on that. So maybe we set the bar a little too high in terms of the recommendations. So if we look at BMI in terms of adverse events, there is a limited recommendation. Certainly, these folks are at higher risk for fracture, dislocation, infection, wound complication, and we're talking double to triple those risks. But when the risk is 0.8% for an infection, and if your BMI is 42, again, the complication rates are higher than a normal BMI control, but the absolute rates are still low. So when you're talking about withholding a life-changing surgery, I'm still not terribly comfortable with, the recommendation of saying, you cannot have surgery if your BMI is 39 or 40, but you're debilitated and you can't walk. It's really hard to lose weight. There are some folks with, biologically speaking, they just can't modify their diet to the point where they're going to lose weight. And I would be interested to see during the Q&A session what the primary care doctors think about, these new medications that are coming out in terms of weight loss, which I think hold a lot of promise. In terms of clinical outcomes, again, another limited recommendation. Patients with higher BMIs greater than 35 to 40 may recover more slowly, but to be honest, they were probably more debilitated prior to surgery. And based on our studies, their magnitude of improvement is dramatic and it's similar. And again, there is limited data over the BMI of 40 because some people are unwilling to entice that or take that risk. So how do we mitigate risk? And this is something that I'm passionate about. This is some work that I did during my years at IU. This is a study that we published in 2018, in JBJS. So, when I first started my practice in 2015, I came from New York, skinny, sexy patients, didn't have to worry about smoking as much, didn't have to worry about the morbid obesity, but part of my training was at the University of Iowa, so I was used to dealing with many of these issues that I'm currently dealing with in practice. And one of the things that we started doing was extending oral antibiotic prophylaxis. So just historically, oral antibiotic prophylaxis has not been used in primary hip or knee replacements. We did actually utilize it briefly, or not briefly, we still do it on a study of reimplantation after infection, and the results for the first 6 months after reimplantation after an infection, when we continued oral antibiotics for the first 3 months, reinfection risk dropped dramatically by over 3 times. So based on some of that information and the fact that we were operating on patients who were potentially high risk, 3% infection versus 0, we started using this extended oral antibiotic prophylactic regimen for a week in patients when I started at IU in 2015. So some of my co-authors are listed here. So the goal of that extended oral antibiotic prophylaxis was to evaluate whether this regimen beyond the traditionally accepted 24 hours of IV antibiotics could minimize periprosthetic joint or PJI in high-risk primary joint replacement patients. Certainly that may call into some questions in terms of antibiotic stewardship and are we causing any issues with that? But we can discuss that later. This was a study cohort, and I guess I would like to emphasize. So I'm going to go through this study that our academy guidelines would consider a medium or low quality study because it's not prospective and randomized. But at the end of the day, I think the science is valid. And so that's why, I think there's more information to be gained from some of these granular studies than from the prospective randomized, which are few and far between. So our study cohort was over 2,000 consecutive primary total hips and knees, performed over a 5-year span by 4 fellowship-trained surgeons, same hospital, same protocols. We retrospectively reviewed those and collected data, and there were about 2,250 patients after exclusions. We derived what was considered high risk from the literature and also based on our own experience. So a body mass index of over 35. And again, some surgeons don't do surgery on folks over 35. Some make a cutoff of 40. That's arbitrary. We can talk about that as well. But again, that was almost 40% of our patient population, 17 diabetes in terms of percentage, 10% active smokers. And at that point, we weren't forcing them to stop. And part of the reason I personally and we at Forte have forced them to stop is some of the results of this paper. So in terms of results, so Group A was not an at-risk for PJI group or infection group. They were not given extended oral prophylactic antibiotic treatment. So that was Group A. Group B was at risk for periprosthetic joint infection. This was before I actually got to IU Health Saxony. So this was, pre-2015. This was kind of our control cohort. So at risk, but not given extended oral antibiotics. So potentially this is an obese patient with diabetes and just had their standard treatment, standard antibiotic IV regimen. Group C was the at-risk patient who received the oral antibiotic regimen and also had the surgery, and that was post 2015 once I got there. So if you look at the 90-day, so the 3-month periprosthetic joint infection rates by group, Group A, which was the healthy group, no antibiotics, 0.9%, which the national average is about 1 or 1.1% just globally. If you looked at Group B, so that was before we started this antibiotic regimen of 1 week of consistent oral antibiotics after they left when they were high risk, they were 3%. And if you look at Group C, which was the high risk group with antibiotics, they actually dropped lower in terms of their infection risk. So an 81% reduction in infection in the high risk group over greater than 2,000 patients. Again, the Academy would call this adequate information, but not exceptionally good information. This probably wouldn't even make it into their recommendations. So in terms of a risk factor analysis on 90-day infection rate, the big things for me are diabetes, BMI, and smoking. So, if you look at BMI, obese patients do just fine with total hip and total knee replacements. And with this protocol, the risk of infection, drainage, et cetera, dramatically increased with a significant p-value. What really struck me was that the smoking cohort, they did not drop significantly. So smoking is a non-starter. For me, it's a non-starter for our team at Forte because we really do want these patients to do well. And usually that's more of a personal choice. So again, their risk reduction was not significantly affected, even with the addition of antibiotics. And to me, that's because of the immune modulating effect, the macrophage effect in terms of the nicotine. And so I spent a lot of time talking with patients about smoking cessation. And I guess in terms of risk mitigation, maybe that's something that we can come together on and really emphasize. So in terms of conclusions, the Academy CPG guidelines, they provide an initial framework for evidence-based care for our patients with hip and knee pain. Their term high quality orthopedic evidence for many of our decisions, it's relatively lacking. I mean, I'm slightly offended by the fact that we haven't done better in terms of our orthopedic research. But at the same time, it's difficult to do that when you're talking about BMI 40, BMI 35, and talking about, prospective randomized trials. So I feel like our academy set a relatively high bar with respect to the required quality of evidence to be included into their guidelines. And they do a good job mitigating that if you really, delve down into their guidelines. In that common sense and the full clinical picture really dictate care. And that's where I think there's a lot of opportunity for myself as an orthopedic surgeon and for my colleagues who are, primary care physicians or kind of boots on the ground, where we can collaborate in terms of how to mitigate risk, but still make sure that patients get excellent care and are not necessarily left in the dust because, they're having a hard time quitting smoking or their BMI is 39 or 44. Again, I think these patients still need excellent care, and it doesn't necessarily preclude surgery. The one thing I did want to spend at least a few minutes talking about, which is kind of just outside the box or outside the realm of this discussion. So patient follow-up. So, as an academic surgeon, or at least my history as an academic surgeon, I'd like to see my patients back every several years. I like to know the quality of the product or the implant that I put in. I like to see that it's going to last 20 plus years. So when I tell a patient who's having hip or knee surgery, how long is your hip or knee replacement going to last? My answer is I expect it to last 20 plus years. And that's based on historical data, but that historical data is based on following patients every 3 to 5 years in perpetuity. Now, the quality of the implants that we're putting in, whether it's robotics or anterior hip or higher quality polyethylene plastics, I expect all these implants to last dramatically longer than the stuff we were putting in 20 years ago. We just don't have the data or the research to support that. So, as primary care doctors that hopefully I'm talking to, I would emphasize, continue to go back to see your surgeon, every 3 to 5 years. If you have an issue, again, you're seeing these folks hopefully every 6 months or a year, especially as they have more medical issues. And sometimes these implants just don't work well. We've had issues with metal on metal more recently. And again, this is the Exactech recall I mentioned. We've had issues with the polyethylene product that was, from this specific implant. So in the area in Carmel, in Noblesville and Fishers, there have been thousands of implants put in, and the plastic with this Exactech specific implant was improperly packaged, allowed oxygen to get into the implant. That's caused degradation of the plastic or the bearing surface that can cause severe polyethylene wear. Hopefully, I'm not sure if you guys see if my pointer works, but basically severe breakdown of the bone, which is called lysis, and that can cause catastrophic clinical failures, which if we see it early on and we know it's a recalled implant, oftentimes we can talk to the patient about a more moderate or minor procedure to kind of obviate those catastrophes. Several surgeons in the area use these implants over the last decade. So again, if you're seeing patients in clinic who have had a hip or a knee replacement and maybe they're having some achiness or some pain or they haven't seen their doctor in 5 years, again, I would just recommend, going to see a surgeon, getting some x-rays, making sure you don't have a recalled implant, because there are definitely, many of these floating around, whether they were put in through the Franciscan system or if they were put in up in Noblesville. So just kind of one little plug to support your patients to make sure they don't have these catastrophes. Other than that, it's 6:40, so we got 15 or 20 minutes to have a Q&A if you guys are interested, but I'm very appreciative that you spent the time to listen to me have a chat tonight, and hopefully you learned a few things. Amy, are you still there? Do you want to take back over? Or?
I am still here. I do not see anything in the chat box. And let me just make sure nobody has their hand raised. They didn't before, but let me make sure. Don't have anybody that has a hand raised. Oh, wait, yes, we do. Dr. Lockhart.
Hey, yes. Thank you so much for your talk. We really appreciate hearing all these updated guidelines. As a primary care doc, I am curious about how many times do you have any limits about injecting steroids and degradation of cartilage or anything like that? Can you speak to repeated intra-articular knee injections, please?
Well, so, part of it depends a little bit on the age of the patient and what the radiograph looks like. So I see a lot of patients, they're like, and they tell me, well, my doctor or my, physician said, well, I can only have a few injections or this or that. Um, so what I've seen clinically is that, if you have a completely normal x-ray, yes, I would be hesitant to recommend a ton of injections because there is an immune modulating effect and there is a potential chondrotoxic effect of the steroid if you do it consistently over a long period of time. So if you have a normal looking x-ray, it may be a potential issue that we should be looking into deeper. If you already have arthritis, the damage is already done. And so what I'm really looking for there is the patient being happy, modifying their ability to function. Um, so chondrotoxicity or degradation of the cartilage or worsening progression of the arthritis, exceedingly rare, as long as you're kind of waiting every 3 to 4 months after an injection. And so, the research we've done, in terms of how the steroid modulates the local immune effect of the knee, is that, if you do surgery within 3 to 4 months, or if you have another injection within 3 to 4 months, then maybe you have like an additive issue if you continue to do it. And so I really don't have a finite number as long as they're still working. So I've had patients that I've been injecting every 3 to 4 months for 3 or 4 years, and they keep coming back. And I say, your X-ray looks terrible. And they say, my knee feels good with the injection. And I say, come on back when it doesn't work. You can't really ruin it to the point where I can't fix it with a knee replacement with an injection, if that makes sense.
Yes, that does help. Thank you.
But I would not tell a patient you can only have 4 injections and then you have to have surgery. As long as they're getting good relief from the injection, and I tell them if it was my knee, if it was my dad's knee, I would still have the injection, not the surgery. That would be my preference. Surgery is excellent, but there's always risks inherent to that.
Thank you.
Other injection options, again, are a little bit more outside the box. So the data on like platelet-rich plasma, the data on viscosupplementation, anything, more biologic or more aggressive than that, I think we have high hopes. But there's a reason they cost more and often insurances don't pay for them. And most of the patients that come see me in clinic already have more significant arthritis. I have a really hard time trying to lubricate a bone. So if you're bone on bone, viscosupplementation just doesn't work in my opinion. PRP, it's your own blood. We spin it down to the local biologic elements. I do think it does have a reasonable anti-inflammation effect. I have a hard time believing with severe arthritis it's any better or more cost efficient than a steroid, but with a younger patient, it makes a little bit more sense to me. Thank you for the question, by the way.
Of course.
Okay, John Herr also has his hand raised.
Hey, Luke, great talk. This is John Herr. I'm one of Luke's partners. I do hip and knee replacements as well. There was a recent study that I read, so I was doing my CME as well, regarding injections in hip arthritis. And the study showed that if you do more than 2 steroid injections in the hip prior to a hip replacement, they saw an increase in relative risk of infection after the total joint replacement. So the recommendation there was for hips anyway, to give 1 injection and really not recommend any more than that. If the plan is to do arthroplasty for that hip. So in my practice, if a patient is hurting but they have a big trip planned, for example, and they're gonna be doing a lot of hiking and walking through Greece or something, then I think I'd recommend a cortisone shot like a week before, just so they have a good time for that week, because you don't know how long it's gonna last. But beyond that, for treatment, for hips anyway, it's not been recommended due to data of the risk of infection. I don't think there's been a similar study for knees. Thank you.
Yep, and I would echo what John said. The hip and the knee are completely different in terms of the injection options and conservative treatment. Not a ton on the hip side we can do conservatively. I've looked at the study John mentioned, and part of the reason the Academy won't, they haven't updated it since that study came out. But again, it's a single study, and the high bar that the Academy would set in terms of utilizing that as a recommendation study, and a little bit not dubious. The study's not dubious at all. It's just, what the high bar we've set as our own Academy. But I think John's point is absolutely valid. So again, I'm not a big fan of injecting hips, to be quite honest. So I'd agree with him. Additionally, it's harder to inject hips. It should be done under ultrasound or X-ray guidance. A knee injection, which again is kind of what I was more alluding to, which is more the cross section of primary care versus orthopedic versus rheumatology. Most of us are comfortable and confident injecting a knee, and I think that's where kind of that cross section is. Thanks, John, by the way.
I think there's another question regarding stem cell injections that doctors are charging $2,000, $4,000 per injection with no evidence behind it. So that's something to. Any thoughts on or literature on that, Luke, on using stem cell injections?
Yeah, I mean, so to be quite honest, I've looked into it, and I've talked to Matt Nygaard, who just for the other folks on the call is kind of our injection ultrasound guru specialist. So I listen to him when we talk about outside the box concepts that, as a surgeon, I'm not looking to inject everybody. I'm looking to fix them. But certainly if fix is not the most appropriate thing, we're looking for the next best option. In terms of stem cells, there's a reason insurance doesn't pay for it. It's because there's not a lot of good research that's supported. There's not a lot of prospective randomized trials. And, conceptually, I don't really understand how it works. People ask me, can't you make cartilage in a lab? And the answer is yes, but I can't give it the structural infrastructure to support the demands of a knee if you want to go jogging on it or if you want to walk and hike, in the mountains. I mean, that's the issue. And I haven't seen any great stem cell literature, but I've seen a lot of patients in clinic that said they spent $2,000 and, it was more of a placebo effect and they would have rather just had a steroid injection. John, what's your anecdotal experience been?
I'd love to have it in my practice. It would make a lot of cash, but I can't. I'd have to sleep with look at myself in the mirror, and I just can't do that. I think it's unscrupulous, to be honest with you, that these people are taking cash for that kind of injection, placebo injection at best. And if anything, similar to the hyaluronic acid, the viscose supplementation injections. They are effective in some people just because of the temporary anti-inflammatory effect. But that's about it.
Yep. So no science that I'm aware of that's validated and vetted to support it. Stem cells hold, potential, but it certainly is a wine before its time, in my opinion.
Dr. Brody, did you have a question?
Yes. I had a question. Do you have any experience with pain reduction using geniculate artery embolization for knee arthritis?
So I've not, in terms of geniculate artery embolization, I can't say that I've had any experience with that. I've heard of geniculate nerve ablation, both preoperatively and postoperatively for residual.
Nerve.
So I don't have a ton of great experience with it. Certainly not preoperatively. We had used Iovera for a period of time, which is more of a freezing, which would do the trick, but didn't see a ton of dramatic clinical benefit. And when it was hard to get insurance to pay for it, it was a little bit cost onerous. Postoperatively, we do have the rare patient who has not necessarily intra-articular postoperative pain, but more superficial nerve or soft tissue pain. And I do kind of refer that out as a modality, but I'm not aware of any excellent literature which supports that. But certainly if somebody's struggling after surgery, which a certain percentage of knee replacements do, It's a modality that we're throwing everything at the problem. John, any thoughts?
I've used it anecdotally a handful of times. It worked amazingly on a few patients where they had no pain whatsoever. I think one patient took a hydrocodone just because she bought it and felt like she should use it, but really had zero pain. So that was awesome. And then I had a chronic pain patient that I thought it'd be useful for, and of course, chronic pain trumped all. So she still had pain, of course, 10 out of 10, as they always say. I do use it on patients who are not candidates for surgery. So say you got a 95-year-old or even a 60-year-old with horrible health history. I'll use that, and I found that it works 7-8 months at a time, and then you just redo it. Unfortunately, insurance companies don't pay for it, so we stopped doing it because no anesthesiologist wanted to do it anymore. I talked to our physiatrist, Dr. Del Busto, just this past week about bringing that back up because I have patients who are willing to pay cash for it because they heard of its effects. And it would cost about $1,000 cash to reimburse the equipment, the disposables, and Dr. Del Busto's time, which is about 30 minutes to an hour. So we are thinking about bringing it online. So that is an option, but it will be cash only.
And part of the problem is the patient population and the response is so heterogeneous that it's going to be so hard to define actual success when you've already got an option for most patients, which is just fixing the problem, which is already has a high success rate. So that's been what's slowing us down in orthopedics in terms of really defining some of these questions with excellent research in terms of pure science, because we already have a pretty good fix, and logic usually dictates what we do anyways, which is both good and bad, I guess I would say. Okay, Amy, any other concerns or?
I have one other quick question, if you don't mind.
Okay.
When you recommend pre-op physical therapy, how long does the patient need to do physical therapy before you see the benefit, even in the post-op period?
John, you want to take that, or I'm happy to?
So insurance companies like Anthem require physical therapy in order for them to get approved. Medicare with an Anthem supplement will also require the same. Usually it's just one visit just to check the box for them. If I'm recommending physical therapy as a treatment, I'd say it's 50-50 in terms of efficacy, depending on the patient. So I always recommend physical therapy for knees. I think it's pretty ineffective for hips. But again, Anthem requires it, so we'll send them for one session just to check the box for them. But they're miserable and they just want to get it fixed. So that's my take on it. Some people are very deconditioned, so I'm going to recommend physical therapy for a prolonged period of time prior to surgery, and I think that's always helpful so that they get a jump on the post-op rehab.
Yeah, I would echo that. I think for a hip, it's not terribly relevant. The hip mechanically is a ball in a socket. It's a simple joint. The muscles around the hip are usually pretty strong, and even if they're terribly conditioned, they're only deconditioned because they're trying to move a bad joint. With respect to a knee, I think that, even a bad knee, you can still work on your quadriceps strength, doing isometrics and other modalities that can, improve and honestly make the surgery and the recovery better. The rehab after a knee surgery is a dramatically different beast than the rehab after hip. Like that, I think after surgery, I recommend both, but the knee surgery rehab is absolutely mission critical. as opposed to the hip, where if they just disappeared off the face of the earth, they're still going to have a great outcome. It may just not get there as fast. Without the therapy after a knee, we worry about stiffness, we worry about quad strength, the range of motion, swelling modalities. So the stronger they are going into the knee replacement, the better off they're going to recover. So I'm a big fan of preoperative therapy, at least to some extent, with some teaching sessions for the knee. The hip, again, for me, it's more dealer's choice.
I think the takeaway points for the primary care docs is when you see a patient with suspected knee and hip arthritis, get the appropriate x-rays. 4-view knee x-rays, I think most x-ray techs understand what that means. And that'll cover all the x-rays Dr. Worth was talking about. And then an AP pelvis and a frog pelvis of the hips. That way you just don't get one joint. You look at both joints and you can compare one to the other. And it's very educational for the patients to see what a good joint looks like and what a bad joint looks like. And then the first line, I always, first line treatment that I always start with is physical therapy, especially for the knee. Not necessarily for the hip, but for the knee. So I think that's what I would do if I were primary care doc is physical therapy. Second line is NSAIDs and Tylenol. I think NSAIDs with Tylenol taken together work great together. I think after that, the third option is cortisone shots. And then if that doesn't work, I would then refer.
Yeah. Well, and I agree with John wholeheartedly. The one thing that I would also add to that is, patients are, often tell me, I don't need therapy. I'm super active, or I walk as much as I can, but my knee hurts. And the way they are active, the way they work out at their gym, what kinds of exercises they're doing can be modified significantly to optimize strength and mobility, but minimize more irritation to the arthritic process. And so I spend a lot of time talking to patients about why therapy is still good, even though you are conceptually still an active human being. And so the concept of isometric quad strengthening or short arc range of motion and not doing more impact type activities. Again, I think all these are things, patients don't really understand. And so I spend a lot of time talking about that, in addition to why I talk about weight loss and smoking cessation. And if you explain to them why it's important, a lot of times they're very receptive, and a lot of times they're going to, improve their quality of life in the short term. And then when they actually do need a hip or knee replacement, they're going to improve their opportunities to get better faster.
Well, thank you.
Okay, anybody else have any questions? We don't have anything in the chat box.
All right, well, right on time. And everybody, thank you very much for spending an hour or so to listen to us. And John, I do appreciate you chiming in. It's always nice to have a second brain to help answer some questions. Certainly we think about things slightly differently, but still, the patient care and ensuring we do a good job, is paramount.
Okay, great. Well, thank you so much for presenting. We really appreciate it, Dr. Worth. Appreciate everybody's time and attending. Thanks so much, everybody. Have a good evening.
All right, cheers.